Okay, welcome back to Parenting in the Trenches. I am with Dr. Julia Bledsoe today, who is a medical doctor and board certified pediatrician at the Pediatric Care Center at UWMC. This is a mouthful, and I'm dyslexic, so I'm going to take my time with this one and try and decode some of this. Okay, so University of Washington Medical Center, correct? Okay,
That's correct.
Roosevelt, and the Center on Human Development and Disability at UWMC.
That's right.
And a UW professor of General Pediatrics. She also works as a faculty pediatrician at the UW FAS, or Fetal Alcohol Syndrome Clinic, and which is the longest standing FAS center in the whole of US. Amazing. Dr. Bledsoe specializes in adoption medicine. People, I cannot be more excited about this discovery. I did not know there were people who specialized in adoption medicine. So the care of children and families who are touched by adoption is her main focus there. She strives to create active partnerships with her patients to achieve the best possible outcomes. Dr. Bledsoe earned her MD at the University of Washington. She lectures and teaches on topics related to international and domestic adoption, especially where these things overlap with fetal alcohol syndrome. I am very eager to hear about how you got into this work. Would you maybe give us a little bit about how you followed this path, what got you here, and a little bit about the work that you do specifically with the Center for Adoption Medicine?
Well, thank you so much for that introduction. And it's interesting when I think back, of course, I'm, 30 years into my career now, but I first became interested in adoption medicine primarily because my husband and I adopted a little boy with cleft lip and palate from Korea in 1996. Okay. And our agency became interested in sort of putting referrals by me in terms of saying, hey, we had this kid with this birth defect, or we have this baby, we have this question, would you be willing to look at the paperwork? And it became clear to me that it was not only an interesting area of medicine, but also one that was sort of just beginning. And the very first international adoption clinic in the US was at the University of Minnesota. And Dr. Dana Johnson, my friend and mentor, really sort of encouraged me to work in this field. He said, Julie, there's hardly anybody, west of Minnesota doing this. And I think you'd really enjoy it. And I'd be, happy to be your mentor and support you. So when I came back to Seattle in 1998, I decided this was the area of medicine that I was most interested in. And so in my pediatric practice, I started to continue to do sort of pre-adoption reviews, which is looking at paperwork for families who are adopting from overseas. And, having a conversation with them about, if I were adopting this child, what are some of the medical issues I would consider, but also what are some of the behavioral and developmental issues that I would anticipate in this child? And I sort of started this clinic around the time there was a huge influx of primarily healthy children, healthy girls being adopted from China due to the one-child policy. Right. And simultaneously, in the early 2000s, there was also the availability of Russian orphans for families in the United States that were interested in adopting children. Korea, which is where we adopted our child from, has always had sort of a relationship with the United States because of the Holt family, who really started the first international adoptions with Amerasian adoptions from Korea. But as I started to see more and more children, particularly children from Russia and Eastern Europe, one of the things that became very apparent was that many of these were children who were affected by alcohol and alcohol exposure prenatally. And so I was running back and forth with my files and my videos of children to the fetal alcohol syndrome clinic folks at the University of Washington saying, hey, is this FAS? Is this not FAS? And they said, you need to come work for us. And it's really serendipity for me that fetal alcohol syndrome was first discovered at the University of Washington in 1973. This is the first place the term was coined, and it has the longest running clinic. And it's been a really interesting dovetail with my work with adoptees. Um, I will also say that while the first sort of international adoptions from Russia were primarily in healthy children, China has moved more and more to a special needs pool.
Okay.
So when I'm doing medical reviews, and I have a wonderful pediatric partner, Julian Davies, been with me now for 17 years. And so when we're looking at referrals, we're often seeing kids with birth defects. So we have a chance to talk to families about special needs, children
Yeah.
in particular, and what they might anticipate in terms of medical care, what they might anticipate in terms of special things they should think about if they adopt this child. So I'm just a general pediatrician, but I
Yeah.
have spent the last, 25 years primarily taking care of kids who are adopted. For many of the children, I will have looked at their pre-adoption records. If they're local in Seattle, I have a chance to be their pediatrician.
Yeah.
I just said goodbye last week to a 22-year-old who I met in paperwork
Oh,
from Vladivostok, Russia. So
unbelievable.
yeah,
Oh.
and it's a very rich field that I've really really enjoyed, um, and has been a very rich field of study for me.
Yeah. Can I ask how accessible your services are? So does this clinic run privately? Who can access it? What does that look like? I'm just curious before we jump into some of the questions I have that I'm sure that some ears are perking up of listeners who are either exploring adoption or have recently adopted and wondering like, "Ooh, is this something we could benefit from?" Is that an option for people?
Well, yes, it is. We have, I would say, with the pre-adoption consultations, only about 15% of the referrals I look at for families are local families.
Okay.
So most of my pre-adoption work is actually out of state. So I'm working with families, on the East Coast, on the West Coast, up in Canada.
Nice.
I think the farthest away we had a family living in Bahrain who
Oh,
asked us to review uh, their adoption packet. For taking care of children after adoption,
mhm.
we do a fair amount of what we call the post placement evaluation. And we now know that when we see internationally adopted kids, there are a certain set of labs and tests and evaluations that are recommended for those kids. So some families will come to us just for a one-time post-placement evaluation. It's about a 90-minute visit, but we, do hearing and vision and laboratory work.
Mm.
And, some families, I have a cute family who adopted a girl from China, but they were living in Japan, and they would come to Seattle every year for her well visit.
Yeah.
So we sometimes do one-time pediatric care, and then
Okay.
for people who are local, we certainly can follow them over time, just as their general pediatrician with a twist.
Incredible. What a resource. The the aftercare I get, you'd want to find someone to add to your village that is close to home. But what struck me when I located you, um, was the gold mine of a resource it is to know who to go to when you're querying what a proposal might look like if you were to accept it. Um, and risk factors already, as an adoptive parent myself, I remember filling out those forms like 15 years ago now, 16 years ago, and remembering how like I got stumped on those. I could answer all the other questions. I'm like, yep, good on this. Oh, that's fine. Oh, here, I'll be open about this, and this is my past, and this is whatever. I could do those things, and then I got stuck on question 8 when it had these little ticky boxes of risk factors, and I'm like, I don't know anything about half of these. Like, so I'm a mental health practitioner, I'm a clinician, so I had some experience in mental health pieces. And so I could say, I feel competent in helping a child through their anxiety or through, a history of mental illness in the family history. But when it comes to drug and alcohol exposure in utero, I don't know the first thing. And I didn't know who to go to. So just knowing that that's an option, and now as somebody who in my work supports a lot of adoptive families, oftentimes that's the question. What if 6 of these factors come toward me and I don't know what that combination means, and we've got 24 hours to say yay or nay, and that's a big decision, not knowing what I'm saying yes to. And so many, of course, emotions, right? How do you say you're in it and
Right.
there's a child in
Right.
front of you, and this is the time where it's the not the time to want to research. You're going to want
Right.
some assistance with this. So, as if we think about that period of time when we are preparing and confused and doing our research, could you help us understand some of those categorical pieces around medical flags, things we should be paying attention to, know more about, and what are the key pieces we should know about?
Yeah. That's an excellent question. And I remember very vividly another one of my mentors in the field was Dr. Jane Ellen Aronson, who's in New York. And I remember her saying to me, our role as a consultant is to help the family make this decision with their head as well as their heart.
Yes.
And it is that has stuck with me
Yeah, good
in
advice.
that, and I think particularly the longer I'm in the field, what you do realize is um, there is this funny element of choice when you're looking at a pre-adoption referral.
Yep.
And for me, I never want to tell a family, oh, yes, you should adopt this child, or no, you shouldn't.
Right.
What I
Yeah.
want to look at is through the lens, okay, if I were adopting this child, what would I be thinking about?
Good.
And
Yeah.
for me, sort of, I have a little bit of a system in terms of how I look at this information. One is to look, of course, at birth family history.
Okay.
And we know that many children relinquished for adoption are relinquished by parents who often can't take care of them for a variety of reasons, right?
Mm-hmm. Mm-hmm.
Sometimes it's out of wedlock birth, sometimes it's poverty, sometimes it's mental health issues, and
Yeah.
sometimes it's addiction, right?
Yeah.
Substance use issues. And so I'm looking, in terms of, are there risk factors in the birth family history that could, be inherited by this child or have an impact on their learning and behavior, long term. So I certainly, often look at the birth family history. Sometimes we don't have that. And of
Right.
course, with China, where it's still against the law to give up your child for adoption, it's a little bit of a blank slate, right?
Yeah.
It's a bigger leap of faith because we have none of that history,
Right.
either of genetics or of exposures during pregnancy.
Hmm.
So that that is something that is different for every country. But in addition to birth family history, also looking very much at medical conditions, right?
Hmm.
And so there are some special needs we see very commonly, and Dr. Davies and I have made it our practice to not only learn about special needs that come up all the time, but also be able to consult specialists.
Yeah.
So for example, a child with cleft lip in palate, knowing what that means in terms of numbers of surgeries. These are possible outcomes.
Hmm.
These are things to watch for if you're taking on this special needs. So we often, with a special needs referral, will walk through that medical condition
Hmm.
and also engage specialists if we need to. The other thing that is very important in adoption is environment. And, when I first started, almost all of these kids were in orphanages.
Right.
And we know from years now of research about orphanage life is that the brain does have some impact from early childhood experience, right?
Mm-hmm.
And in an orphanage setting, that's often, not, not optimal attention, not
Mm-hmm.
optimal nutrition.
Yeah.
And so we often, in kids in orphanage settings, we look at them, how are they doing compared to other kids in the orphanage? We expect them to not grow as well as kids in a family, but how much is their growth affected?
Mm-hmm.
And then for kids who are profoundly neglected, or kids who are coming out of a situation where they experienced early childhood trauma, like abuse or profound
Yeah.
neglect, we know that those things affect the developing brain just as much as prenatal exposures to alcohol and
Yeah.
drugs, right? So it's
Yeah.
it's looking at what are the things in this child's history, the background, their location that can help me say, gosh, you know, Is this a kid at particularly high risk of a genetic syndrome? Is this a child at particularly high risk of having poor brain development? I think that's
Yeah.
important to talk about with families.
Yeah.
So, in terms of the consultation, that's really what I'm looking at.
Amazing.
And then, I'm very honest with the family is, um, what are their expectations of this child,
Yeah.
right, in terms of a special need,
Yeah.
and and I very vividly again remember talking with Dr. Johnson and him saying, you don't ever meet a pregnant woman who says, "Oh gosh, I hope I have a child with profound disabilities," right?
Yeah. Of
if they have
course.
if they have a child with profound disabilities, then everybody steps up to the plate.
That's
It's
right.
just
And we
knowing
don't
as
wish that for people.
right.
Right. Right.
But and I think there are situations where it's very clear. I'll give you an example of a child whose brain is growing extremely poorly.
Mm.
And when we see brains grow extremely poorly, particularly if they fall way off the growth grid,
Mm.
it dramatically increases the risk that this child will have intellectual disability, which means an IQ below 70.
Okay.
And if a family uh, already has children in the home and they're
Mm.
thinking about adopting, you really have to think not only of the ramifications of
Yeah.
this on you, but also, if this child requires lifelong care, the impact on your other children in the home, on your financial state. I mean, there's some families that can more easily afford the
That's right.
special services that these kids
Yeah.
will require. So while those are
Mhm.
hard conversations, I still feel like
Mhm.
it's important, again, to make the decision with your head as well as your heart.
I always find myself so much more comforted by people who are planning to adopt, who have and open up the hard conversations, who I can witness being um, showing some capacity to have those hard conversations, because that I feel like, okay, then the learning can happen and will happen, and then you're intentional with your decisions. There's purpose behind this, and you understand what you're stepping forward for, which is such a different place than if we are only being guided by a sense of hope for family
Right.
or a sense of having a child. And of course we want to just close our eyes and say love is enough. I'm just going to say yes and we'll figure it out. And I get that balance is tough because in most cases you will figure it out, but there are options to make this a better case scenario for every person in the adoption triad, right? That
Right.
everybody gets to experience a better match for the needs that are involved, both for the child and for the rest of your family. Yeah.
It's
Yeah.
interesting you say that because one of the lines I often will use is, to me, the match is, it's important for your family. It's also really important with a child with significant disabilities. They need someone who really can go to the mat for them, right?
That's right.
And that
Yeah.
may not be you.
Yeah. And that's
I,
okay.
and that's okay. That's
Yes.
okay.
When it comes to categories of drug use, can you, because there were two factors that I remember being super aware of, was the type of substance, well, actually three: the type of substance, the intensity of use, so the frequency or yeah, how much was used, and when, right? What
Mhm.
trimester.
Mhm.
And I remember being told that because, and you alluded to this, like countries like China, you might not get any family background information. But I remember we adopted from Florida and we're in Canada, and that the process there was that the social worker would just ask for self-report. There was no actual measurable thing that would say, yes, we know that you have drank at this point or had this substance in your bloodstream for this long. There was no way to measure that, and so because of all the stigma attached to that, the warning to us was, whatever's on the report, presume it's 3 times as much. And it felt so dishonoring to not want to trust,
Yeah.
to start our relationship with the birth family in that way. And yet I understand that there's systemic factors that require people to self-preserve and be careful. And they too want their child chosen.
Right.
They're planning intentionally for the care of their child who they love deeply. So you don't want to sabotage your chances. So I understand that for so many reasons it goes underreported. but with all of those factors in mind, I remember thinking, okay, well, how am I supposed to calculate? How do I
Right.
calculate that, in addition to I don't know anything about methamphetamine use in a first trimester? What does that mean? I don't know what that means. Like, is that a week of detoxing after birth? Is that like developmental delay into their 20s? I don't know. Can I know you we can't cover all of this, but are there
I can
certain
try.
like, yeah, just try like
Yeah.
cocaine use versus, oh, that's the other thing,
Yeah.
the myth of alcohol versus drug use. That's a common one. People freak out about one because of what's been taught to them, and it's probably not accurate. So I'll just let you have the free
Yeah.
reins on that one. You just tell me what you think we need to know about just what we should be aware of.
Yeah.
Yeah.
And this is, obviously because of my involvement in the fetal alcohol syndrome clinic, rarely do we just see alcohol in that clinic.
Right. That too.
Often there
Yeah.
is other drug exposure, and we'll often see kids who've been exposed to some alcohol, but primarily other drugs. And so this is certainly an area of interest and expertise for me. Dr. Davies and I have written a couple papers on it, and as well as done a foster care training, a national foster care training curriculum. And you just reminded me, it was really funny when we were writing the article. I was talking to him on the phone, and I said, "You take meth and cocaine, and I'll take alcohol and tobacco." And then we were like, "Oh, I hope nobody's listening to us."
Yeah.
But it
I
is
get it.
it yeah, but it
Yeah.
is very interesting, and you've pointed out to some really important factors. Is particularly with alcohol use, the problem of people underreporting their use also plays very much into um, the problem of addiction. And alcoholism in particular is a disease, right, that
Yeah.
people have, that they minimize and deny their
Right.
their problem.
Of
And
course. Yeah.
so, I will say it's been very eye-opening. I've worked a fair amount with Korean adoption agencies. And in Korea, there isn't the stigma attached to drinking during pregnancy. So often the Korean referrals will have very specific amounts of how
Okay.
much women drank. But you're right. I think in general, we have to think, oh, there's exposure. You know, you may want to think it's more than what's reported.
Okay.
Um, we know after years and years of research on prenatal drug and alcohol exposure that by far the most damaging drug to the developing fetus is alcohol. Alcohol is what we call a teratogen, and a teratogen medically means it has been shown to disrupt normal formation of the brain, not only in terms of anatomy and architecture, but also in terms of messaging, and that brain damage is permanent. Um, the tricky thing about alcohol is that the outcomes for kids exposed to alcohol are really variable. And what we know, like you said, the dose of alcohol is very important. We also know that in general, if it's an older woman having a pregnancy, like say a woman that's 40 years of age who's an alcoholic who has a baby, it's probably going to be more affected because she's been drinking for a longer time and her tolerance
Interesting.
level to alcohol is high. So
Wow.
the fetus experiences more alcohol exposure.
Okay.
So we do know the most damage is done by women with high tolerance who drink throughout pregnancy, but primarily the first trimester is that really, it's when the central nervous system is being formed.
Yeah.
It's interestingly also when the face is being formed, which is why sometimes the face
I
is a good marker
see.
for us.
Aha. Yeah.
Characteristics of the birth mother, certainly dose and timing of alcohol use. And then there is this sort of difficult thing to quantify, which is there are some fetuses that are more susceptible to the effects of alcohol than others. And we did a few years ago a study at our clinic where we looked at 40 sets of twins and looked at outcomes. And what was fascinating is that the identical twins were always affected the same. The fraternal twins were not. And in half of the fraternal twins, one of the twins had fetal alcohol syndrome and the other did not.
Wow.
Now, full blown fetal alcohol syndrome. Now, the ones that didn't have full blown fetal alcohol syndrome often still had disabilities much more mild or moderate in nature.
Okay.
And what that tells us is there's something at the level of the baby's own metabolism alcohol that can either be protective or not protective against alcohol exposure. We also know that if I always like to think of it as you think of the brain as a circuit board, depending on how much birth mom drank and when, different wires are clipped, right? So we see
Yeah.
kids, sometimes there are a lot of things we see in common. We see a lot of ADHD and impulse control problems, but we often will see these kids with a lot of learning disabilities and behavior problems right next to areas of strength. Like I had a patient, a Russian adoptee, who was an elite level gymnast, and yet
Yeah.
she really struggled in school. So you
Yes.
see this patchy area of strength and weakness.
Yeah.
You also have to think about, we saw a young man in clinic who, both his birth parents, incredibly intelligent. Their IQs were in the 130s, like super high.
Wow.
And birth mom drank a fifth of vodka throughout the first trimester. His IQ was 110. Now, he probably took a huge hit to his IQ, but
Yeah.
because his genetic potential was so high, it was not nearly as dramatic,
Compensated.
right? I mean,
Right.
if he'd
Okay.
had an IQ destined to be 100 and took a 30-point hit, that would be a big deal.
Yeah.
Now, not to say that he didn't have some struggles with learning and
Sure.
behavior.
Yeah.
So prenatal alcohol exposure is tricky in that
Mm.
there are a lot of factors that go into it. But in general, if you are exposed to alcohol during pregnancy at any sort of moderate level, you would expect learning disabilities and often difficulty with emotional regulation are the two most common things we see.
Yeah.
We know that ADHD is by far the most common learning disability. That prefrontal cortex, the front part of the brain, that's our secretary in the brain, is the most affected, sort of followed by math and language disabilities. Um, Interestingly enough, when we look at cocaine, of course, in the 1980s, there was a crack cocaine epidemic, and there was a lot of concern about crack babies and the
Yeah.
devastation they were going to experience. And that research didn't pan out.
Interesting.
Cocaine definitely could increase risk of prematurity, and because it's a vasoconstrictant and the babies would come early, but it does not have the pattern of learning disability, the reliable pattern of learning disability that we see in prenatal alcohol exposure. A lot of people who did research on cocaine in the 80s went back to alcohol research when it wasn't showing as much a
Yeah.
pattern.
Yeah.
Um, the other one that's very interesting is methamphetamine, which is a little bit of a newer drug,
Yeah.
relatively speaking. But what we know about methamphetamine is surprising because we see what it does to the user, right?
Mm-hmm.
And yet the impact on the fetus is much more subtle in terms of, we do know that there is a pattern of big motor skill delay in the first
Yeah.
2 years of life. Sometimes can get better. We know there can be a withdrawal from methamphetamine actually in the newborn period.
Yeah.
And we also know that there are some indications that, 8 to 10 years down the line, these are kids who do also seem to have a slightly increased risk of learning disabilities and ADHD, but not nearly as dramatic as alcohol.
Okay.
Um, Opiates are very interesting in that, you remember, we don't have any naturally occurring alcohol receptors in our brain, which is why it
Okay.
causes damage. But
Yes.
we have naturally occurring opiate receptors in our brain. And so opiates like heroin,
Yeah.
oxycodone, and even methadone, what they do to the brain is they don't change the structure and architecture, but they upregulate those receptors. So when a baby's born, they go through withdrawal. And
Oh.
so, the neonatal abstinence syndrome is something we've seen an increase in nurseries all over the country. But once you get out of that newborn period, typically you have a pretty normal brain. And so it always sounds
Interesting.
very
Wow.
strange to say
Yeah.
that you'd rather be born to a heroin addict than an alcoholic,
Right.
because the long term impact, we do know what one of the best studies was done in Canada, where they sort of looked long term at children that stayed in the birth home versus children who were adopted out who had opiate exposure. And they did see a slightly increased risk of teenage anxiety and depression
Okay.
in kids who've been exposed to opiates during pregnancy. But which always raises the question, was the
Yeah.
birth mother self-medicating, right, for alcohol and
Yeah.
depression. And then, but in terms of IQ and sort of basic IQ, that was really unscathed in kids with significant. If it was just, again, it's hard to control for
Yeah.
just pure opiate.
Yes.
The
Well, I was going
problem
to
is,
say,
yeah,
I mean, even the risk of depression and anxiety in teenage years, I'm thinking how much of that is just attributed to the fact that they were placed for adoption.
right,
I mean, the adoption trauma, the
right,
attachment trauma has significant impacts on our mental health
right,
later on. So
right,
that wouldn't be a surprise if those are the control subjects or the ones that are staying with their birth families, right?
right.
Wow.
I often,
Yeah.
and you raise a very interesting point that one of them, I think the most complicated things about this field is I call these children my onion children, right? Because they
Mm-hmm.
have so many layers. So you may have a child with prenatal exposures, with the trauma, early childhood abuse or neglect,
Yeah.
adoption placement, which
Mm-hmm.
disrupts attachment, and
Yeah.
they may have a genetic potential for mental illness, which expresses itself in adolescence, or they
Right.
may have a genetic predisposition to addiction. And all of those things, it's this really complicated tapestry of things. And I see the whole range. I see some kids that, when I did their pre adoption referral, I was really worried about them.
Mm.
And for reasons that we don't necessarily understand, they really seem to go through life unscathed. It's this
Yeah.
concept of resilience, right? Why
Yeah.
are some children who have these experiences really profoundly impacted, and why are some that seem
Yeah.
very resilient to even
Yeah.
the same trauma an orphan mate had, right?
Right.
So they are, they're complicated kids, and really, I think my major message to people is to follow them really like a hawk, so that if they have
Mm.
learning disabilities, we can get on it right away, right? Don't
Early
wait and watch.
intervention.
Yep.
Yeah.
If they're in adolescence, you see any signs of anxiety or depression, get them into counseling. I mean, I would prescribe a therapist for everybody, quite frankly. But
Yeah.
watch
Yeah.
monitor their mental health. Make sure they know their risks, potential genetic risks of addiction. Be very frank with them about, in their teenage years that, you may have had addiction in your family history. You may be alert. I call it allergic, right, to
Yeah.
alcohol.
Yeah.
React very differently than other people.
w- I think it's so hard to imagine when you are in the proposal phase of adoption and you read some of the paperwork and it's so normal to wonder what is this picture going to look like in 20 years from now, right? So wanting to kind of see the trajectory of what we can expect, and like anything else that is impossible to nail down and to perfectly envision, and that's okay. But I don't think I don't think it's avoidable for people to want to predict a bit, and that's just a protective preparation
Right.
mechanism, right? I want to be best prepared for this. So to some extent, we can't avoid the question, but we also have to acknowledge there is no way for us to paint an exact picture of what you can expect. Are there things specific to what you have seen in patterns because you've been doing this for so long that if there's, mild to moderate alcohol exposure throughout pregnancy, what that typically looks like when kids are, in their middle school years or beyond?
Yeah.
Yeah,
Oh gosh, that's a really hard question.
it is, isn't it? I know
It
it's
is. I
unfair,
mean,
but
it is.
yeah,
I mean, the hard part is we may not we may not know the child how much exactly the child was exposed to, right?
that's right.
And
Yeah,
we may not know what their genetic potential is,
yeah,
and we
yeah,
may not know what the family's history of learning disability is, right?
yeah,
So when I talk about ADHD being the most common learning disabilities we see in kids who are exposed to alcohol prenatally,
mm,
we also have to remember that ADHD is very inheritable. I mean, if you have a parent with ADHD, you're about 60% likely
yeah,
to have ADHD.
yes, yeah,
So, what I would say for mild to moderate alcohol use, moderate I get a little nervous about, right? Because I know there are some kids exposed, fetuses exposed to moderate alcohol exposure who can really have some significant issues.
Yeah.
For mild exposure, and I do, occasionally get panic phone calls from women who, drank before they knew they were pregnant, right?
Yep.
And are worried about the impact. And, what I will often say to them is, well, first of all, don't borrow worry, right?
Mm.
We all we can do at this point is to watch these children very closely. And so early development, get them to early intervention if they need it. And I would say for a kid with, moderate to severe alcohol exposure, what I'm worried about with them is all areas of development: motor development, big motor skills, fine motor skills, language, and what they early sort of problem solving for kids. And if they have delays, get them early intervention. The time where we see are really able to test for learning disabilities and even for IQ. IQ really isn't stable until age 8. And remember, you may have a kid with very significant alcohol exposure or even the full fetal alcohol syndrome who look pretty good as kids because we don't expect them to do more higher order thinking, right? We don't
Right.
expect them to do sustained
Right.
focus attention,
Yeah.
do complicated things with
It
language,
doesn't stand
do problem
out.
solving. Yes.
Yeah.
And so often, I'm saying to families, please have their learning looked at in detail
Mm.
at 7 to 8 years of age. Because if they
Okay.
have a subtle learning disability, I have a son with dyslexia, which was pretty subtle, and
Mm.
yet it had significant impact for him in
Yeah.
school.
Yeah.
So, so get that really detailed IQ testing, learning disability evaluation. It's basically what we call neuropsychometric testing. It tells you how
Yeah.
your brain works. What are your
Yeah.
strengths? What are your weaknesses? So that if you have weaknesses, we can bolster them with your strengths, right?
Beautiful. Yeah.
And so it's, but if I were adopting a kid with, fetal, with prenatal alcohol exposure, things I would think about are attention deficit disorder. I would move to a school district that has excellent special ed in terms of supports, right, for a child because they may need it. Again, I'm
Yeah.
preparing for the worst, right?
Yeah.
Um, there are often markers or clues in the referral that this will be a severely impacted child. I talked about one of them, really poor brain growth. We
Mm-hmm.
know that the facial features, if you have all three facial features of fetal alcohol syndrome, that is a window into your brain that predicts a more damaged brain. We
Okay.
also know that growth stunting, and a lot of people forget that prenatal alcohol exposure can stunt growth both in and out of the womb, and it is a marker for brain dysfunction. So sometimes when I'm looking at a referral, I can say, oh, so far this kid doesn't have a face, their growth looks good. Could they have learning disabilities down the road? Yes. Are they likely to have intellectual disability? Probably no.
Okay.
But they may have trouble with behavior regulation. These are kids
Yeah.
that,
Yeah.
we've got really good evidence based tools to help kids regulate their emotion. Make sure that's on your plate. Get a good child psychiatrist who can help you with med management for impulsivity, for
Yeah.
attention deficit, because those are tools that sometimes will really help. And get parental support. That's the other thing is, sometimes these really challenging kids, you need a village, and you mentioned it
Yes, you
already. You
do.
need a
Yeah.
village,
Yeah.
and parent support for other families that are raising these children can be really imperative.
I had created a course that really centered around helping couples who were adopting to center their own relationship and ensure that they were, creating a secure base. And and how we learn to attune to one another gives us the skills to attune to our kids' needs and to adapt to what they need. And as I was writing the modules for that course, I kind of stopped at module 9 and I'm like, no, something's missing. Something's missing. Like, what do I know something's missing? It's the village. Because more times than not, if you are an adoptive family, it comes inherently with complex needs of some kind, of some kind. And yes, it varies and the type varies and the amount varies, but I want people to assume that when they begin their journey to adopt, that they're going to need a support network that maybe they haven't assumed they were going to need. And so not to wait until your child is 4, 5, 6 years old to realize reactively, oh no, we're in over our heads, or this feels really hard and we feel isolated and alone and I can't get out of the house. And it's, we try to help parents identify ahead of time. You might not know exactly what you're going to need, but to go in with the mindset that you will need more than just you is such an empowering position, I think, while you have the resources and you can think this through and you can assess, do we need to move? Do we need to be in an environment or a community that reflects our kids' racial identity, to reflect trauma evidence-based services, to reflect adoptive groups? Do we have, right? And so I think it's just so important that we shouldn't neglect that piece and just think we're this little insular kind of siloed little group of people that are just going to get through the adoption part and then we just carry on as though we're a bio family. And it
Right.
doesn't, for the most part, look like that.
I mean, that is probably the wisest advice is, to go in expecting that you will need support and have supports built in. I
Yeah.
think that's really, really fabulous. Um, yeah.
Do you
And
know, in your experience, what types of resources for kids, particularly who have experienced this prenatal exposure piece, what are the types of services you would say, watch for this, research that, look for those things? Can
yeah,
you name some of those?
well, I would say that I think if you have a child who may have been exposed, especially to alcohol prenatally, it might be worth your while to have a specialty evaluation by a fetal alcohol syndrome clinic.
Okay.
The good news, especially for Canada, is that there are a lot of people who know a lot
Yeah.
about fetal alcohol spectrum disorder in Canada. And so even if things are going really well, I still think that can give you, again, a better window into how the brain is and what potentially to expect down the road.
Mm.
So if I build my village, you have to think of school, of course.
Yeah.
You have to think of people who understand adoption,
Yeah.
like you, honestly. People who, and often it's people who've walked the talk.
Yeah.
It's an interesting
Yes.
thing that understand adoption. I think you have to know who in your community. I always tell families it's really good to know your mental health community,
Yeah.
who has experience with early childhood trauma, right?
Yeah.
As kids get older, are there therapists that have some adoption savvy that the teen could talk to as well?
Mm.
And obviously good medical care. I'm biased about that. But parenting is hard, period. And
Yeah.
parenting is a leap of faith, period, right? We never
It
know what
is.
we're going to get or
No,
what's
it's true.
down the road. I mean, even as a pediatrician, I was shocked by how much I felt like I didn't know.
Yeah.
But adoptive parenting is special because it does have that layer of complexity.
Yeah.
It has the unknowns,
Yeah.
often the unknowns of genetic and early womb environment. But it is impactful throughout the life cycle to be adopted.
Yes. Yes.
And you did it beautifully, mentioned all the things. Do you want to have the only Asian kid in your community?
Yeah.
It's a transracial adoption or
Yeah.
African American child. Those
Yes.
things can be very important in
Right.
subtle ways that we might not appreciate. I remember saying, "Oh, but our family's colorblind. That's lovely, but the world is not." And so, being able to prepare and be honest with yourself and with others about things that may come up in the absence of a
Yeah.
crystal ball, but you can prepare for a
Yeah.
lot of them.
Yeah, and I think it sets us on a trajectory of assuming we don't have to know it all when we begin the journey, but this is never going to be an end of learning. If we stay open, right? I'm every day reading something new that I go, oh goodness, that did not occur to me, or I did not think from that lens. And the more adoptee voices I listen to, where I think, man, from that perspective, that enlightens. That's just so much for me from what my kid's vantage point would be that they can't yet articulate, but I now know what's likely happening for them and I can be attuned to and responsive to, but it doesn't end. I mean, we're
Right.
entering teen years, but it's every day is still a thing that I'm like, oh boy.
Yeah.
Yeah.
I think the
Yeah.
other thing I'm very cognizant of is I remember, if you look at sort of the mental health literature, seems to be an overrepresentation of adopted children in the mental health that seek mental health services.
Yeah.
And I remember thinking, oh, is that kind of depressing? But I'll have to tell you that if the Joint Council of International Children's Services, which existed for many, many years, would survey adoptive parents every year, and 97% of adoptive parents felt like they were with the children they should have been with, regardless of need for mental health services
Yeah.
or special medical needs.
Yeah.
And I think that if you do, adoption is special. They have special needs, but they also have a special richness
Yeah.
to raising them. And
Yeah.
I think it's hard to pinpoint that, but it's very, very real. And what a
It is.
statistic! 97% of adoptive parents feel like they are with the children they were meant to be with.
We need to end there. That was like the end of the rainbow just landed on the ground there. That was lovely. Thank you for that hope and for that just all the concrete information we managed to pack in to this 45-minute conversation. That was incredible. I'm so grateful that you do the work that you do. I wish I had known about you a long time ago. We would have been on the phone with you in particular. And I would, yeah, I'm excited to share the resources that you have put forward, and I'll tag some things in the show notes as well to make sure people can follow up. Thank you for your time today. I really appreciate it.
It's a pleasure to be here.
Thank you.